We have a full 15 minutes for a robust panel discussion. If you have questions, please come up to the microphone, and we'll start with Paul.
Hi, great session. Looking forward, Andy, for the CPU to be imprinting gastro. What I would like to do, though, is defend the AGA guideline. There's a lot of criticism of it, and the criticism of grade, really, as well. And I come from the home of grade, and it's there because of applying evidence-based medicine. And I agree with you, Joo Ha, that convoluted wording was not helpful. But what I would emphasize is that when you don't know stuff, you have to tell the patient that. And that's what that was all about. You have to have a frank discussion that actually what you might be doing may not do as much as you think it will. And time again in medicine, we think we're doing great, and we're not. And only when we do randomized trials and good quality observational studies do we work that out. If we just pronounce that this is a good idea, we run the danger of misguiding our patients and not doing what we should be doing with healthcare dollars. The reason I'm making a plea for this, as you know, I'm an evidence-based medicine guy, and we've done a large randomized trial in Barrett's esophagus. Are we really doing as much as we think we are? And you've made a lot of comparisons with Barrett's esophagus today. I can't reveal the results of that randomized trial. It's still being reviewed. What I will say is, just like many other studies, it shows we don't do as well as we think we do. So my plea to you is, I think this is analogous to Canadian doctors who are always saying, I want to get paid more, and always, not all, but most vote for governments that lower their taxes. Who do they think pays their salary? It's the taxes that pay their salary. So you can't ask for more money and less taxes. Same here. I actually passionately love what this conference is doing and think we should institute programs in high-risk populations. However, only if we do good quality research to show that it's working. If we don't do that, we're like the Canadian doctors who are complaining about grade and saying, because it has no evidence, and yet passionately saying we must do it. I don't know what the group feel about that point of view.
I mean, I 100% agree with you. I think that the challenge is in trying to make recommendations when we know that the data isn't there. Right? I think it's much easier when we do have good randomized controlled trials and it's positive or negative or equivocal, you know, when we actually have good studies. But in the absence of good studies, I completely understand with this philosophy, but I think and I think people who understand it, we can apply it well, but I think it confuses the larger community. And I think that it often gets misused. That's the danger, right? I mean, they'll take a low quality evidence, you know, conditional recommendation, low quality evidence. They don't read that part, right? They just read the recommendations, and then, you know, insurance companies and other people, you know, apply that as if it's high quality evidence, strong recommendation. And so I think that, you know, there's some education that needs to go on with the guidelines as well, and it should just be a little bit more clear. I think we all agree that, you know, we need to be evidence-based. You know, this is evidence-based medicine era. It's just a matter of how it gets applied.
Joo Ha, can I just add to this point? I think I'm wondering if the fact that it is somewhat ambiguous, maybe there's benefits to it. For example, if there's no guideline, then, for example, if you want to do a patient preference and shared decision making, you have no cover for it. You know, I can even think about trying to get an upper endoscopy reimbursed and writing some kind of prior approval, and then you say this is in the AGA guidelines. I think that'd be very different. And I'm also wondering if it impacts third-party payers. That at least it's in the guidelines as an option, low evidence, versus there's nothing out there. So I understand the need for clarity, but I think there's some benefits to something there with full disclosure rather than nothing. So,
Can I make a remark? I think I totally agree first that you need evidence and that you also need to be very clear on the evidence that we lack. In fact, there was a reason why I deliberately started first with zooming out a bit and giving a little bit of perspective of public health and clinical medicine. And having been a politician myself, I also know that many people come to you and say, well, we need money for this, etc. So, and yet, having said that, I think there is great value in actually making the guidelines and sometimes also stretching it and be very clear in terms of your grading or not, because this is a double-edged sword. Not making the guidelines and not making the recommendations and not doing a review means that we can continue forever not doing anything. And as I showed, for instance, in terms of the pathway towards gastric cancer, these studies already date back to the 1950s. Whoa, 1950s. That's 70 years ago, 75 years ago. And everything afterwards was always consistent. So we can put in different parts of the puzzle and then still say, well, there are many things that we do not know, but at least let's try to bring it forward a bit, and you do need guidelines for that. And that's also why we actually update these guidelines, or I look at Andrew, sometimes not deliberately not make it a guideline, but make it like a review, a statement, or whatever. So total agreement, but the importance also of having a meeting like this and hear all the beautiful presentations is also to make us aware where are we now and how can we go to the next step.
And I will say, I echo that completely. Paul's comment is dead on. You know, I think the systematic review, the grade analysis is important. I think the point John made years ago about the right PICO question, I think, is key too, because if you get too ambitious and you run into a wall, you know, there's nothing there and insufficient evidence, or you come out with a weak conditional recommendation that could swing either way. But I do want to thank Paul in particular because he did help us usher through this CPU, which is actually, I think, a really Herculean task and a way to move the needle forward in the U.S. A lot of it's about communication. This is an expert review. It's not a guideline. But payers and people who are learning, who are practicing, will use it as a kind of a compass of sorts. And I think that's it's really positive communication.
Yeah.
Well, and I'd also like to thank Paul, and I think you're absolutely right. We need to, as we move forward, we need to rigorously study what we're doing and understand whether we're making a difference or not. One of the problems would be if we don't do anything, 5 years from now, we're still not going to have any data. So, and we face a major cancer disparity, and we can approach this with some precision.
Yeah, and you know, the whole role of this summit is to say, where are the gaps? I mean, and where can we potentially fill the gaps working together? I think the next session is going to be very enlightening, and I like to think that the next session is happening in part because of the years that we've put into this. I think this has all been an evolution. We need good prospective randomized control trials. Where that's not possible, we need to do our best in, you know, either doing prospective registries, following patients longitudinally. It takes time, you know, we fully acknowledge that this is a marathon. We acknowledge that, you know, we think, you know, we know certain things, but, you know, again, we could be wrong, we could be off the mark, but if we don't investigate it, that's the danger. I mean, I think that, you know, we have to at least push the envelope somehow. The worst thing that we can be are nihilists and just say, oh, I don't know, and it's not a problem. And so, and I think that to some extent that's what happened kind of the past 20 years. It fell under the radar, and it was, you know, not much attention was paid to it. But, you know, I'm very reassured just by the presence of all of you here, you know, shows that there is plenty of global attention to this, and we can make an impact. And I think really I go to Asia so many times, and to me they're at least somewhat of the model. I mean, they've really shown that they can improve survival for gastric cancer, and I think that's what the draw is. Our outcomes are just so poor. To me, it's low-hanging fruit. We should be able to do better, and I think that should be our goal.
Well, I think what I like is the statement, let's just make an ambition and say, can we achieve a 5-year survival rate for gastric cancer above 45%? Yes, we can. But then we need many steps, including training our fellows and ourselves, etc.
It's not going to happen just by continuing to do what we're doing. We showed that graph. It's going to be 25%, right? I mean, so, we got to do something. And, if we fail, we'll learn from it. But, the worst thing we can do is not try.
So in my practice, I'm seeing a lot of patients referred by the primary physician with FOB positive test for colonoscopy. And then, on the other hand, I celebrate that the surveillance after intestinal metaplasia diagnosis is going to be probably 3 years, as some of you are working for that guidelines. My question is, what do you think, this is for all the panel, how can we bring all the patients out there that have intestinal metaplasia, no diagnosed before, to the endoscopy room to be diagnosed with intestinal metaplasia by biopsy, and then make it a surveillance every 3 years? For colonoscopy, we do have the FOT. And again, many patients are coming to my GI clinic saying, I need a colonoscopy because this. You see this is positive. Primary physician has referred me. And there's a bunch of patients, there are a lot. Any thoughts about biomarkers? Any thoughts about what can we do to bring all the patients that we need to come?
I don't have any wisdom.
Because they are not coming. They are not coming by themselves.
No, but I think there may be some consolation and reflection in the fact that CRC screening and surveillance started with surveillance, right? And understanding that process, which was part evidence and part political, to move to appropriate screening, there may be some lessons therein for gastric cancer. Even gastric cancer has always been the stepchild, right, of the esophagus and the colon. But why? Because there hasn't been a visual biomarker, at least in U.S. hands, correct? And we're finally at least aligning surveillance in the stomach with what we already do in the esophagus and the colon.
Yeah, I also think, I see the analogy, the FOBT or the FIT, or really the fecal DNA FIT now, is actually the screening test, and so the colonoscopy has become diagnostic. It's all paid for now. I think John helped us usher that through with the AGA and other societies. But I think we also have to realize EGDs are overprescribed, overdone in the world, and in the U.S. too. And so, say we continue to do that, though, but we create all of them high-quality EGDs, you're going to find a lot more. Yeah. It's the 1 to 2 minute EGD that finds nothing. But if we're going to do all these extra EGDs, which you can make a case we do too many, but if you actually are doing good quality EGDs, we'll find a lot more.
Yeah, I can add to that, and was my remark very much in the same lines. First, if we do adequate endoscopy for those that already are being done, then it will have a significant impact on the people itself, but also on their direct environment. And we heard this very impressive story this morning about somebody just by chance you're diagnosed with gastric cancer. My guess is this will have an immediate impact in your direct environment, even more so with all the further work that's being done in other people saying, hey, wait a minute, I want an upper GI endoscopy as well. And so this is one which is very similar to what happened in the past with colorectal. Now, if we look at the European perspective, the uptake of colonoscopy for colorectal cancer screening is very low. So we use the non-invasive test, the FIT test. And that's why also, as we heard this morning, for instance, in Baltic countries, this is now combined with Helicobacter pylori serology and pepsinogens for all the limitations of the pepsinogens. But we do know that gastric intestinal metaplasia is very rare in people who, at least in the past, were not Helicobacter pylori positive. So an alternative approach is, but then at a somewhat younger age, as our MAPS guidelines also state, test for Helicobacter, non-invasive, so serology or breast test.
I think to add to all this conversation, the bottom line is, I'd rephrase that as, how do you convince someone who is asymptomatic that they need a test, right, to prevent cancer, right? And it's always harder to get a patient who's asymptomatic to undergo an invasive, procedure. Review the IARC and the WHO, they're writing, this nice paper regarding patients' perceptions of undergoing screening. And the surprising thing is, even if they know that they're at risk, they don't want the screening procedure because it's invasive. They're afraid of the test. I think the only way to get over that is similar to what we've done with colonoscopy, is it's education. It's like, without educating not just the patient but the providers, of the benefit. And again, this goes to Paul. The benefit is, uncertain right now. So it's a dialogue with the patient, and, it's ultimately their choice, right? But we have to provide them the best data that we have, and they have to make the decision on whether or not they want to undergo an upper endoscopy. And again, people who have seen patients, their friends or family members die of gastric cancer and how difficult that is, they volunteer very readily. So, because they've been educated. So I think that it will take time to get there. But again, we got to keep trying. We got to keep educating. We got to keep informing. We got to keep getting good data to further educate, and eventually we'll get there.
So, do you have a chance to pontificate?
Pontificate.
Anyway, whenever we talk about adherence, my ears perk up. And I'm going to go back to like the colon cancer screening stuff we talked about. In terms of the whole U.S., there's only like 68% of people are up to date with colon cancer screening. And that's why, on the other side, the 80% by 2018, 2019, so, and that one has, well, a little more evidence. A couple people have referenced the study from Taiwan today. I think Lee was the first author, and that's the one where they randomized 250,000 people in a couple of counties in Taiwan, and then invited 150,000 people. And they invited people to either FIT alone, because they had a biannual FIT program, or a FIT plus the HB stool antigen. And I happened to handle this paper at JAMA, and it got very complex because, as it turns out, there was differential uptake. So the people who were just getting the FIT alone knew that it must have been for colon, because only 35% of the people did colon cancer screening by FIT. The people who knew they were getting the FIT plus the HB stool antigen for gastric cancer, that adherence was 50%. So it was unexpected, but there was a differential uptake because people knew something about gastric cancer and somehow that they're at risk and they should get it done, more so than colon cancer screening. Well, that screwed up the whole thing. On the intention to treat, 50% uptake in one and 35% in the other. And so where's Constanza? She actually wrote the editorial on this thing. It got very complex because the intention to treat or as randomized ended up being a null study, no difference in gastric cancer incidence or uptake or mortality. But if you did either adjusted for differential uptake or adjusted for like the per protocol, then you had like a 20 or 30% reduction incidence. So it goes back to a couple things. One is, what is like the best strategy? And what is, maybe tomorrow we're talking, what is the best screening study to do in the US? And in this one it was HP stool antigen. And Ernst, you're talking about maybe a serology. Joo Ha wants to do endoscopy because he's got kids in college and he's like, yeah, that's how we make, right? I mean, so.
We don't get paid much for
I know, thank God, my God. Your travel I don't have to pay for either anymore. And so but the issues really are, hopefully by tomorrow we have an idea about what is the best kind of design of a screening strategies in a big randomized trial. And and I know, I'm not sure, you said pepsinogen is like, We talked about that. We talked about serology. We talked about HB stool energy. We talked about endoscopy. Maybe we don't have an answer right now, but this is the time we should decide. Well, here's our screening study. And what's our comparator, right? Like I said, in Taiwan, it was FIT alone versus FIT plus HB stool antigen. They had some really interesting things. Or should it be screening versus no screening, invitation versus no? Human behavior gets in this thing, and it gets all messed up.
Yeah. So the reason for mentioning the pepsinogen again, like Julie mentioned, I'm not advocating it. I only mention it in relation to a question, and then explaining why Marcis Leia and colleagues decided to use this in their study in the Baltic region, and it was for the purpose of low uptake of endoscopy. With all the remarks, Paul also mentioned it about the potential, but it's a study and we have to see. Now, in terms of the actual impact, my firm belief first is that, and it has been mentioned, it's not in a study, but in the clinical setting, if the first thing we can do is actually, for those who undergo an endoscopy for whatever reason, turn it into a proper endoscopy, not a 1-minute quick procedure where you identify the pylorus and the angulus or the incisura, but turn it into a proper procedure. It doesn't take that much more time. You can still do a whole lot of procedures on a day, but then you have the actual benefit. With a quick one, you might as well not do it, as has been mentioned. And once we have that, then you can make major steps into the next step.
Yeah,
but for the screening purposes, if you want to do a study, well, we know from all the evidence now, you either go for H. pylori testing and treating, but you have to do it at a relatively young age and not wait till somebody is 65 or above. And when it's for the pre-malignant lesions, the best one is an endoscopy, provided that the uptake is sufficient, and for that you have to do the education and explanation.
Yeah, my belief in going back to Joo Ha's friend that started this off with a $5,000 bill, I think screening is going to be the way, but with the way that our healthcare system is going with these high, deductible plans, unless you get a screening test that's paid for, it's not going to go very far. And I actually think, Hejun In is not here, but she's led a couple of us in the room in this DoD grant that we hope will get funded to look at opportunistic endoscopy, and she has some early data. I actually think if we cast a bigger net, not just stomach, but you catch the Barrett's, you catch the duodenal adenomas. The EGD is not just a gastric exam. It's an exam that can catch all sorts of things that might have downstream benefit. I think if you put it all together, then at least one EGD in your lifetime at a time of colonoscopy probably will make sense for everybody.
Yeah, I actually have one of my fellows back here who's doing his master's in epi, and I told him, look at that, because there's so many different findings. I mean, we're so isolated here. We're just talking about gastric cancer, but if you look at the risk factors for everybody, there's Barrett's, there's different types of gastric cancers. There's all kinds of lesions that we can identify, and I completely agree with you. Let's do a proper exam and find out what we find on these.
So I showed you the results of basically 3 studies, one from the US and 2 from Europe, which did that in a population without any specific clinical indication for upper GI endoscopy, but then just asked them to be included in a study, and while they came for a screening colonoscopy, also to undergo an upper GI endoscopy, and I showed you the prevalence of lesions, and that's quite high. You actually even have, for surveillance, you have to make a further selection because you can't follow them all.
Exactly. Well, I want to thank everybody on the panel and my co-moderator, John Inadomi, for a wonderful session. Please give them a hand. Thank you.